All right, welcome everybody. Thank you for coming to this year's second Grand Rounds. Last week we had Christine Erlinson give a great talk from the Infectious Disease Division, and we're excited today to have our second Grand Round speakers of the year. You'll see a variety of things popping up here. Take a look in terms of CME, MOC credit. Please scan that and get that going as well. That'll automatically populate. I do want to introduce a few new faces in the crowd. We have two new vice chairs in the Department of Medicine that have joined us. Jen Spicer, please raise your hand, stand, whatever it might be. Jen is our new Vice Chair of Education and just joined us on Monday, an infectious disease physician. So welcome, Dr. Spicer. And then Dr. David Murphy behind her is our new Vice Chair of Quality and just joined us. This is week 3. Both of them came from Emory University this summer. So welcome to the two of them, and we're excited to have you here. On to our presentation today. We are fortunate to have one of our own. Dr. Sunnie Kim is here to talk to us today. Dr. Kim is an associate professor of medicine in the Division of Medical Oncology here at CU and is the director of the esophagastric medical oncology group. She earned her medical degree from Columbia University and followed by residency in internal medicine at New York University Medical Center, and then fellowship in medical oncology at Weill Cornell at New York Presbyterian Hospital. She holds multiple leadership roles in national cooperative groups, such as the NCCN and the American Society of Clinical Oncology. Her contributions to the field are widely recognized, with over 24 peer-reviewed publications and multiple book chapters. She's a sought-after speaker, both domestically and also internationally. She's a dedicated clinician and researcher, and she focuses her efforts on improving our understanding of gastrointestinal cancers to develop more effective treatment strategies. She currently leads 5 clinical trials here at the university, and this really underscores her commitment to innovation and patient-centered care. Please join me in welcoming Dr. Kim to the stage.
All right, I had another keyboard here that disappeared. Okay, there we go. Thank you so much for that introduction. My name is Sunnie Kim. As was said, I'm a GI medical oncologist with a special focus in stomach and esophageal cancers. And I came here in 2019, right before the pandemic. And I was very grateful to be here during that time. My husband is actually a cancer survivor, was treated here at UC Health, and they did a phenomenal job. Dr. Manali Kamdar was his physician. But my focus is gastric and esophageal cancers, and I'd like to discuss recent progress, and there's been a lot, and what our future directions are to deal with this really challenging disease. Our learning objectives today, I'll list the risk factors that are associated with gastric and esophageal cancer. I'll present a patient case identifying key clinical, lab, and imaging studies used to work up GE cancers. And more excitingly, identify key biomarkers and recent FDA and upcoming FDA-approved agents for this cancer. And also describe novel drug technologies and platforms that are already being implemented right now in standard of care, but also in many clinical trials, and how we'll improve outcomes for our patients. So starting off with our patient case, this is a 48-year-old man who presents to the emergency room with severe abdominal pain. He has bloating, has lost his appetite associated with a 10-pound weight loss, nausea, abdominal pain, and dark stools. So the labs are notable for a hemoglobin of 9, a CT showing gastric wall thickening and liver lesions concerning for metastases, an endoscopy showing a gastric body fungating mass, and it's biopsied, and it's positive for poorly differentiated adenocarcinoma. And the biopsy, as I said, showed the adenocarcinoma. So unfortunately, this is becoming an increasingly common case, meaning we're seeing these kind of cancers, these luminal GI cancers in younger and younger patients. This was an article in the Wall Street Journal last year, and this highlighted what cancers we're seeing in younger patients. It's typically defined as 50 years and younger. And as many of you know, we are dealing with a true alarming epidemic with colorectal cancer. We are seeing this increasingly in our 30 and 40-year-olds. But not far behind it are some of the other GI cancers I treat, including stomach cancer and and pancreas cancer as well. And on the right, we see over here that that red line, the 15 and 39-year-old population, we're seeing a sharp uptick in this young onset cancer. But when we talk about globally, because this used to be more of a global issue, not so much of a US issue, but globally, stomach cancer is really centered in certain regions of the world, like Asia and Central and South America, highlighted with the dark blue. And when we look at the male versus female predominance, we're seeing it more in the males than females. Similarly, with esophageal cancer, we do again see this more in the Asian population, Central and South America, but also it's kind of creeping into those Western countries. And we think that it's some of our Western eating behaviors, habits that are contributing to the rise in esophageal cancer. And even more so in esophageal cancer, we see a stark male predominance over female. In the US, this is the latest data we have. It's not even in the top 10, numbers 15 and 18, fortunately, stomach and esophageal cancer. And when we look at when we're finding gastric cancer in the US, it's primarily in the regional and distant settings. In regional, that means that there are regional lymph nodes often involved with cancer spread. And as you can see, the 5-year survival rates are still quite poor. Regional, 32% 5-year survival rate, and then for distant, 6% 5-year survival rate. And that tracks with what we're seeing in our clinics too. And that's similar for esophageal cancer as well. Poor prognosis in the regional and distant settings. Again, want to highlight what we're seeing in our younger populations. This was an article that was published back in 2018, taking a look at the increasing rates of non-cardia. So cardia is right at the GE junction, kind of more distal to that as we go into the small intestine. This non-cardia gastric cancer incidence seems to be rising. And what they did in this analysis was they looked at 45 North American tumor registries, and they found that overall, fortunately, gastric cancer has been decreasing in incidence. However, what they found most alarming, and you can see in the 2 bar graphs on the right, the younger populations, the 25 to kind of 30-year-old populations, we're seeing stabilization or a little bit of an increase, particularly in women. And these are non-Hispanic women under the age of 50. There are a lot of theories. We have the same theories for a lot of what we're seeing in colon cancer, but no one really knows, and it's probably some kind of generational exposure. But some thoughts could be increased antibiotic use, autoimmunity, which is more present in women. We know that there's been changing reproductive patterns, contraceptive use. Again, these are all theories, but clearly it's something generationally happening. This was published at the GI ASCO Cancer Conference in San Francisco 2025, and we're continuing to see that persistent trend showing the increase of young onset GI cancers. And now young onset GI cancers account for 27% of newly diagnosed cancer cases. So again, that's less than 50 years of age, and 37% of cancer deaths. And this presents distinct challenges for our patients, which I'll go into next. I adapted this from a paper on colorectal cancer by my colleague, Chris Liu, but I think a lot of it pertains to our patients with GI cancers who develop them at a young age. And what we see here is that when you develop GI cancers as a young adult, what happens is you're more fatigued from the treatment. We tend to be much more aggressive with our systemic treatments with young patients, a lot of out-of-pocket treatment costs. This is an overwhelming field. So even the smartest people who are not necessarily in medicine will try to do their research, but it's overwhelming to try to sort through all that data. A lot of disruption in their ability to develop career-wise. And again, just speaking to that financial toxicity, all that leads to being in a tough place in this current economic environment. And what happens as a result of that is that the quality of life dips down quite a bit. They can't keep appointments because they're trying to maintain their jobs, trying to work, debt, bankruptcy, and all this leads to poor health outcomes. And so it's so important right now that we develop new treatment options for our patients. So when we talk about the risk factors for this cancer, it's a very heterogeneous disease. I didn't include the esophagus here, but just imagine the esophagus on top of it. And with every section of the stomach, there can be different risk factors that contribute to cancer development in distinct parts of the stomach and esophageal portions. So When we think about what is the incidence trends in the USA for gastric and esophageal cancers, I've subdivided into 4 sections. So esophageal squamous cell cancer, this is usually more proximal in the mid-esophagus, upper esophagus. Those risk factors include smoking and alcohol. Fortunately, smoking obviously has decreased quite a bit. Alcohol has also decreased. So the overall incidence of this cancer has decreased. But when we think about gastroesophageal junction adenocarcinoma, more distal gastric cancer, especially with the GEJ cancers, reflux obesity is causing a rise in the rates of gastroesophageal junction cancer. For other types of gastric cancer, we've done a good job with eliminating H. pylori. We no longer use salt-preserved foods as much. So incidence of those types of cancers are going down. But as you can see, there are multiple subtypes and distinct risk factors that are associated. When we think about modifiable risk factors, that's a main question I get from not only my patients, but friends and colleagues. So the strong evidence to develop gastric cancer is H. pylori infection, which we've, again, done a really good job of eradicating. Smoking, also have done a good job with that. Also associated with industrial chemical exposures, alcohol, salt-preserved foods, and then obesity, which is the big issue right now with our cardia and GEJ cancers. There is some evidence with associations with grilled or barbecued meat or fish, processed meats, low or no fruit diets, and consumption of citrus fruit may actually decrease the risk of GEJ cancers. More on H. pylori. I'm sure this is kind of internal medicine 101, but oftentimes these are acquired in childhood. This is more prevalent in patients outside of North America. And so it's important to know where patients are born. The transmission mode is a bit unclear, but with H. pylori, these organisms produce urease, which are able to neutralize the stomach acid and allow for infiltration, colonization, and inflammation that causes a lot of the issues that we see associated with H. pylori, like peptic ulcer disease and cancer. So when to test for H. pylori, if a patient has long-standing dyspepsia that can't be explained, peptic ulcer disease, gastric cancer, or pre-malignant lesions, if they have autoimmune gastritis or less of a strong indication, unexplained iron deficiency. Barry Marshall, he is the scientist, the doctor who found out the association between peptic ulcer disease and H. pylori. Dr. Wani here from GI probably knows this data very well. And I think he actually even gave himself H. pylori, and then he developed peptic ulcer disease. A truly dedicated scientist. In terms of diagnosis and treatment, an endoscopy can be used. Histology is going to be the gold standard. Urea breath test, which is often used to see if there's increased CO2 production because the urease degrades the urea to ammonia and carbon dioxide. Our first line treatment, this is even different than when I was internal medicine residency about 10 years ago. Now it's a quadruplet treatment that we recommend. And test for eradication is a urea breath test or stool antigen test. No, we do not use serology because that's hard to determine if it's truly been eradicated. But not to scare everyone, the likelihood of H. pylori infection leading to cancer is in the single digits, all the way on the right, less than 1%. In some literature, I've seen 1 to 3%. But it is important to eradicate this for patients' well-being and to really eliminate that risk for H. pylori-associated gastric cancer. Other risk factors for gastric cancer include associations with Epstein-Barr virus, which is a small proportion. But also I wanted to highlight inherited germline mutations, which shouldn't be missed, especially with patients with a strong family history of stomach cancer and lobular breast cancer. So I want to briefly discuss hereditary diffuse gastric cancer. This is autosomal dominant, so usually not subtle when you examine a patient's medical history. So what happens here is that patients have a mutation in a tumor suppressor gene called CDH1. And this regulates cell adhesions. And what can happen is when that gets altered, the cells are no longer kind of in aligned polarity with each other. They start to get malaligned and can start being in places where it shouldn't, causing tumor genesis and cancer formation. And we find that patients who have this, the CDH mutation have an 80% risk of developing gastric cancer by the age of 80 and a 60% risk of developing lobular breast cancer. So what are the indications for genetic CDH1 testing? I won't go through the whole list, but there are family criteria and individual criteria. The family criteria really focusing on patients who have family histories of gastric cancer and lobular breast cancer. But there are also some associations with certain ethnicities as well as cleft lip as well. And what do we do for patients who are confirmed to have HDGC? We recommend a preventative total gastrectomy between the age of 20 to 30. Endoscopic surveillance is not recommended, but if it is chosen, it should be done at a center like ours with expertise and patients who are aware of its limitations, because these endoscopic surveillance tests require many random biopsies, 28 to 30 biopsies in all parts of the stomach. And during, we have a multidisciplinary conference called our Esophageal Gastric MDC, and we often review these patients who have been on surveillance, endoscopic surveillance. And if we find a specimen that's positive for cancer, this is where we'll have the discussion about gastrectomy. In addition, we recommend annual breast MRI and clinical breast exams starting at the age of 30. So going to patient case 2. This is a 67-year-old man presenting with worsening dysphagia for 3 months. It's insidious. He's no longer able to tolerate solid foods, on a more of a liquid diet, and he has a 10-pound weight loss. So how do we work up this patient? Endoscopic ultrasound, CT, something called a diagnostic laparoscopy, and PET are going to be our mainstays of workup. So an endoscopic ultrasound, this is more than our typical endoscopy, but it's a similar idea. Well, they'll do an endoscopy, but this probe will have some ultrasound technology, being able to look at the depth of the tumor within the esophageal wall and also pathologically enlarged lymph nodes in the surrounding area. So in here, you can see where it says T is the tumor invading into the esophageal wall, and you'll see an enlarged lymph node up on top. And this will allow us to really develop precise staging for these patients to be able to develop an effective treatment plan, whether it be surgery only, whether it be surgery plus chemotherapy or radiation. And oftentimes when patients are referred to our center, we'll actually repeat the endoscopic ultrasound because it's a very nuanced procedure that we always want to double check here what the exact staging is. And I'll just go over this briefly. For the T stage, we really care about the depth of invasion versus tumor size, and then also the number of lymph nodes that are involved. A diagnostic laparoscopy is to assess for occult peritoneal disease. And so even with the best PET scans and CT scans, sometimes we cannot see disease that has spread into the peritoneum. And studies have shown that patients who have who are routinely checked for diagnostic laparoscopy have an alarming high rate of peritoneal disease that is missed on CT scans. And so here a patient is brought into the OR, laparoscopes are placed, and they are able to do a direct visualization of the peritoneal cavity to see if there's any cancer spread there. And on the right, on the bottom right, you can see those white spots representing peritoneal disease. In addition, we rely heavily on FDG PET, especially for our GEJ and esophageal cancers, because in a small proportion of patients, we may be able to catch occult metastatic disease here. And in this case, we found a supraclavicular lymph node that was positive for cancer. And this is very important because we do not want to commit patients to esophagectomies, gastrectomies, which are highly morbid surgeries, without really understanding if they would benefit from it. So going back to our patient case 2, the endoscopy shows GEJ adenocarcinoma. CT is negative for metastases, but unfortunately the PET scan does show that right supraclavicular lymph node, which is considered a distant metastatic disease, and we would not offer a curative approach, at least right off the bat. So what are his options? And this is really where I live mostly. I just want to really highlight how many advancements we've had in the field of gastric esophageal cancers, especially since 2021. I've highlighted all the positive phase 3 trials that have occurred. And in 2021, as you can see, it was a very busy year. and many of them were targeted against a biomarker called PD-L1, allowing us to do immune checkpoint inhibitors for these cancers, as well as other treatment options targeted against proteins such as HER2, Claudin 18.2, and FGFR2b, which I'll go over. But it's really been an exciting field. Having said that, despite all these advancements, overall survival still remains a little over a year, at least by the data. I think we're getting better with certain subsets, but to be able to promise patients 5 years of survival with metastatic disease is very difficult. So how do we move beyond chemotherapy? And I have here a pie chart, lessons from lung cancer, because when I graduated from fellowship 10 years ago, we were only able to target EGFR. And since then, the field has completely exploded. And this is really due to all the work from the scientists who were able to really pinpoint molecular subtypes in lung cancer. And now we have patients who have metastatic disease with brain metastases who are maintained on just a pill. And we hope to be able to get there. And how do we get there? And I think the really understanding biomarkers is going to be pivotal in being able to improve the survival for our patients. So what is a biomarker? This is a very general term. The NCI defines it as a biological molecule found in blood or other bodily fluids or tissues that is a sign of normal or abnormal processes or of a condition or disease. So very general definition. When we think about how we use biomarkers for cancer detection and cancer treatment, starting from the left, we know that there are biomarkers that predict your risk of developing cancer, like BRCA mutations. When we do a differential diagnosis, when we have a biopsy of a liver mass and we're trying to figure out where is it originating from, we can do immunohistochemistry on these tests to really find out what is the likely origin. How do we determine prognosis? Patients who have had lumpectomies for breast cancer, and we need to figure out what is their likelihood of recurrence and what should we be offering them adjuvant chemo. These are gene recurrence scores. I'll be focusing here on how do we predict response to therapy, and we'll be targeting proteins such as HER2, KRAS mutations, Claudin mutations. And how do we monitor for disease recurrence? So someone has gone through curative therapy. Do we just kind of just hope for the best? We're trying to get beyond that. And something called circulating tumor DNA may be able to predict for patients who have a high chance of recurrence or a high chance of cure, and be able to to design clinical trials to deal with those patients who have a high risk of disease recurrence. And then monitoring response to therapy. Patients who have metastatic disease, how do we know if the treatment is working beyond scans every 3 to 4 months? We're really trying to focus in on also using cancer antigens and circulating tumor DNA to track their progress on a more real-time basis. So when we talk about biomarkers and going back to this timeline here, as you can see, all these trials were biomarker directed. And I think that's where our success lies. And how we figure out biomarkers is by being able to molecularly characterize gastric and esophageal cancers. This was an analysis done back in 2017, really identifying key molecular alterations within, as we go from top to bottom, esophageal squamous cell cancer, and then other types of adenocarcinoma subtypes, chromosomal stable, EBV associated, microsatellite unstable, genomically stable. I won't go through all of this, but I just want to let you know that we have been really trying to understand the subtypes. This is an example of what the biomarkers that we're testing now, especially for advanced disease, HER2, microsatellite instability, the EBV associated disease, PD-L1, et cetera, because all these biomarkers predict for response to the therapies listed on the right side. So I'll kind of discuss some of these biomarkers, especially the most exciting ones we have right now that have really changed our patients' prognosis. So microsatellite instability or mismatch repair deficiency. So mismatch repair proteins are crucial for maintaining genomic stability, and they correct errors that occur during DNA replication. The proteins that I've highlighted here are MLH1, PMS2, MSH2, and MSH6. When any of these are absent, then we know that there's mismatch repair deficiency. And what can result from that is there's an accumulation of DNA replication errors, and this leads to short repetitive nucleotide sequences. And these mutations actually can alert the immune system that there's something a little bit amiss in the body because there are these mutation-associated antigens that the immune system is more keen to. And so back in the day, before we had therapies against these MMR deficient tumors, what the pathologists would notice was that when they looked at the pathology slide, they would see all these lymphocytes crowded around the tumors, again, highlighting the immune system trying to attack these tumors. And now, of course, we have really amazing drugs that have changed the cancer field, immune checkpoint inhibitors, one of them being our PD-1 inhibitors. And PD-1 binds to PD-L1 on tumor cells. PD-L1 is also present on immune cells as well. And when the tumor cells express PD-L1, it binds to the PD-1 on T cells and causes a downregulation of the immune system, preventing anti-tumor killing. So with these PD-1 and PD-L1 inhibitors being able to block these checkpoints, it allows for the immune system to go then and exert an anti-tumor response. And how does that play for our patients? So one of the trials I wanted to highlight briefly, this is a trial that was done in Europe, looking at patients with localized MSI-high, mismatch repair deficient gastric and esophageal cancers. So how we normally treated these patients before this study came out was we would give them aggressive chemotherapy before and after an esophagectomy or a gastrectomy. These patients are typically older in our population, and they're completely beat up, and it doesn't even guarantee a cure, unfortunately, for these patients. So for this study, what they did instead is they eliminated all the chemotherapy and they just gave them two immune therapy drugs called nivolumab and ipilimumab. These patients did go to surgery. And what we found in that red boxes over here is that 60% of patients were able to have a complete response with just 3 months of immunotherapy before surgery. And on the right, we have event-free survival and overall survival curves showing that the vast majority of patients are still alive over a year out without any cancer. And I have to tell you, I have 2 patients recently who had a complete response after about 2 to 3 months of immunotherapy, and we decided not to put them through a major surgery, and they remain disease-free to this day. And I think it's about 2 years for one gentleman and 1 year for another woman. And so this has completely changed how we treat localized cancer, and also highlights how important it is to do biomarker testing. And then what about for advanced disease? Similarly, we are really changing the prognosis for these patients. So these are 2 kind of post hoc analyses of 2 major global trials. And what they did is they picked out the patients with this mismatch repair deficiency or MSI-high. And as long as these patients got some kind of immunotherapy in their treatment, what we see is 4 or 5 years out, over 50-60% of them are still alive. And again, just going back to standard survival, 1-year survival, it's not great for the vast majority of our gastric esophageal cancer patients. So this was quite remarkable to see. We're also using PD-1 inhibitors for the management of patients who don't have this feature, in addition with chemotherapy. This again highlights that even with this treatment, this is a modern trial. The median overall survival was only a little over a year, 13.7 months. But again, this was in an unselected population. What are other biomarkers to predict for response to immunotherapy? We also find out that the diversity in your gut microbiome can play a factor as well. And this was from Asia, where they see far more gastric and esophageal cancer. But there have been a lot of subsequent studies to see how we can affect the gut microbiome to allow for better responses for immunotherapy. We recently presented our project where we looked at the association of antibiotic use and survival among patients who receive first-line immuno-based therapies for advanced gastroesophageal cancers. So this could be immunotherapy alone or chemo plus immunotherapy. And we used the Flatiron Health electronic medical record system, which pools patient data from community and academic centers all across the US. This was a retrospective multi-center analysis. This was led by our former fellow, Nicole Balmaceda, who's now at MD Anderson. And what we found here, fortunately, is that for patients who received antibiotics either right before or after they started first-line chemo plus immunotherapy, didn't seem to be a difference. But for patients who received only immunotherapy, having antibiotics on board did seem to affect survival. So I think that, again, as we think about antibiotic stewardship, just really making sure that we give antibiotics for a good reason, especially for patients who are starting immunotherapy. Other immune checkpoint inhibitors, there's another one I want to highlight called TIGIT, which is right in the middle over there, amongst many other immune checkpoint inhibitors that are undergoing clinical trial development. And I want to highlight one of our own internal studies. We were interested in combining an antibody against TIGIT with anti-angiogenic therapy, which is approved for gastric and esophageal cancer. And the theory here is that can we normalize that aberrant tumor vasculature and promote better tumor immune cell infiltration into the cells? And so in this study, we did evaluate the combination of a TIGIT antibody, PD-1 antibody, an anti-angiogenesis antibody, VEGFR2, and chemotherapy as well in various cohorts. We work with Todd Pitts, who is our scientist, and he's part of the GI Translational Laboratory. And what we've done here is we have a protocol that where we obtain surgical cancer samples from patients, and we inject them into nude mice in the beginning. And then we transfer them over to a humanized mouse model that mimics the human immune system. And we do this to be able to really get robust preclinical data. And if we find that it's a positive signal there, then we propose a human clinical trial and try to get that going here, not only at Anschutz, but also our satellite sites. And so we've been doing this a lot for our colon cancer and our pancreas cancers. But since my arrival here, we've been trying to implement studies in the gastroesophageal cancer space. So in this study, and this will be presented at an upcoming conference in the fall, we found that the quad therapy in the red line over here did produce a robust anti-tumor effect. But what I think is more interesting is the next slide, and where we divided between each treatment arm, but individual mice. So on the bottom two, the green and the red, we found that there were tumors that we were able to see a complete regression of these tumors, which is not common in this humanized mouse model. And so as a result of this, we are applying for funding to be able to run a clinical trial that combines at least a portion of these drugs to test in our patients with advanced refractory gastroesophageal cancer. Other biomarkers I'd like to highlight, just so you get a breadth of what we're targeting these days. Claudin 18.2, this is a tight junction protein normally expressed in the gastric cancer cells. And what we find that in states of malignancy, this Claudin 18.2 gets expressed into the surface, and it makes it a promising target for drug development. There were 2 global phase 3 trials that looked at the combination of a monoclonal antibody against Claudin 18.2 called zolbetuximab in combination with chemotherapy. And we did find that the combination of chemo plus zolbe resulted in a survival benefit. I'm not going to overstate it. It was only a 3-month survival benefit, but this is what gets you an approval these days just because of just the dismal nature of this cancer. So this is now an option for our patients. Other biomarker-directed agents, HER2, obviously, I'm sure you've heard a lot of it in breast cancer, but HER2 is overexpressed in about 30% of stomach and esophageal cancers. And more excitingly, beyond just Herceptin, we have these drugs called antibody-drug conjugates and one example of this is trastuzumab deruxtecan. And this is a much more sophisticated way of being able to deliver chemotherapy. It's comprised of 3 components. You have the antibody portion on the left, a linker protein, and then what we call a chemotherapy payload. And the idea is that when we infuse these drugs into the body, it goes directly to where the protein is, and it delivers that chemotherapy particle in a more directed fashion. Another drug that we're really excited about is a drug targeting FGFR2b, which is also associated with more aggressive tumor biology, metastatic potential. This is expressed in about 20% of gastric cancer. And there were 2 global phase 3 trials looking at a drug called bemarituzumab targeting FGFR2b. One just read out, it is a positive study, and we're hoping for an FDA approval for this drug in the new year. And the other clinical trial that involves immunotherapy should read out next year. This is just a cartoon of all the biomarkers that have been studied and we are studying. This probably isn't inclusive of all the other biomarkers that are undergoing clinical trial development, but I just want to let you know that there is a lot of movement in this field. And then the next portion, my last portion, I'll be discussing kind of what are our novel therapeutic approaches? What are our new drug platforms that we are trying to deliver to our patients? Some of these have been around for a while, but I think we've done a better job at optimizing them. Bispecific antibodies, instead of a monoclonal antibody, now we're able to target 2 or more epitopes on either cancer cells, immune cells, other cells. Bispecific T cell engagers, similar idea, where we bind to an antigen on the cell, on the cancer cell, as well as an immune cell. CAR T cell therapy, where we're able to re-engineer T cells to target a protein of interest and elicit a very powerful immune response. Antibody drug conjugates I discussed. Tumor vaccines, obviously those have been around for a while, but now we seem to have partners with those tumor vaccines to augment action. And oncolytic viruses, re-engineered viruses to go inside the cancer cell, cause apoptosis and cell death. So bispecific antibodies, just to give you an idea of the most popular type that we're testing in clinical trials. These can recruit immune effector cells to the cancer cell. So in this situation, we have one portion of the antibody binding to the tumor cell and another one binding to an immune cell, in this case, a CD3 positive T cell. And by doing this, we can bring the immune cells closer to the tumor cells to exert that anti-tumor effect. One of the examples of this is zanidatamab, which is being investigated for HER2 positive cancers, not just gastric cancer, but also breast cancers and cholangiocarcinomas. This antibody is targeting 2 distinct HER2 epitopes, resulting in HER2 binding across all expression ranges, because we have typically seen benefit when these tumors are very high HER2 expressing, but now we're really trying to target those cancer cells that have just any HER2 expression. This is most notably seen in breast cancer, where now we're giving HER2 drugs for ultra low HER2 positive breast cancer. As long as there's just one speck of HER2, it seems to be able to result in stable disease. Some examples of bispecific antibodies that are under investigation. Antibody drug conjugates, I've already discussed. We consider these right now to be our magic bullets of cancer treatment due to the ability to target a protein on a cancer cell and allow for a more potent cytotoxic response. And what makes these really powerful is something called a bystander effect, and that's in the cartoon on the bottom. What we find is that when these ADCs bind to a epitope on a cancer cells and deliver the chemotherapy payload actually affects neighboring cells that may not have that antigen expression. So allowing for more widespread killing of neighboring tumor cells. And then right now, these are the current approved antibody drug conjugates in solid tumors. What they all share in common is they have a high drug antibody ratio, allowing the antibody drug conjugates to link to more cytotoxic molecules to antibody. So just a lot more payload to the antibody itself. These linkers, they're cleavable. So when they go into the tumor cells, it allows for a release of the cytotoxic payload to allow for an effect instead of getting just rapidly metabolized. And right now the field is really trying to be more creative in what payloads we administered. So for the most part right now, it's chemotherapy payloads, but can we do more novel drug payloads into these cancer cells? That's an area of investigation. And these are the ADCs under investigation right now in gastroesophageal cancers. CAR T cell therapy, I'll just mention something briefly about that. This was a study that was completed a few years ago where they were targeting Claudin 18.2. This was a CAR that was re-engineered to be able to elicit a powerful immune response. And what we found in this very difficult to treat population, these are patients who are refractory to multiple cancer therapies, is that 60% were able to achieve a response. So a response in clinical trials means greater than a 30% reduction in cancer, which is pretty impressive in a cancer like gastric cancer. But all these therapies come with side effects. I'm sure people who have been in the inpatient setting know cytokine release syndrome very well. Because of this powerful immune response, patients can develop almost like a cytokine storm associated with fevers, myalgias, hypotension, hypoxia. I think that our inpatient team has just done an amazing job. I see one of them here, hello, being able to manage these patients and being able to administer powerful immunosuppressants to be able to make this tolerable for patients so they can receive another dose. And similarly, there are multiple future directions for CAR T-cell therapy target against various antigens on gastric cancer. And then finally, I want to highlight the KDO and Paul M. Rady Esophageal and Gastric Cancer Gastric Center. We actually have our fearless leader here, Dr. Sachinwani, through a very generous philanthropic gift from the Radys. We have a robust center that we would love to make the nation's top esophageal and gastric center here. And how we do that is definitely a multidisciplinary approach. These are our fellow team members. They really span all disciplines, with education, outreach, bench research, our benign GI diseases, behavioral health, and then me. This is our vision to really impact how we treat esophageal cancer on a clinical, research, screening, advocacy, outreach, and educational sectors. This is just kind of the goals that we've outlined for ourselves. And a big plug I want to put in right now is that we do have a research day, October 17th from 8 to 3:30 p.m. We'll be having scheduled presentations, but if anyone has an inkling of learning more about gastric esophageal research or interested in participating in research, we welcome you that day. And we're hoping that this will really jumpstart how we apply for major federal grant funding and really put us on the map. With that, I want to acknowledge many, many people, my fellow GI medical oncology team. I have a great group of GI medical oncologists. We don't take ourselves too seriously. We understand, the big hurdles that we have to deal with. Our research coordinators who do so much legwork for our patients. Our esophagogastric multidisciplinary team. This is every Thursday morning at 7 a.m. where we review cases, mostly resectable curative cases. And we really come up with a cohesive, multidisciplinary plan for our patients. And of course, the Rady Center, which has been a welcome addition to University of Colorado and UC Health. Thank you so much. I'm happy to answer any questions.
Dr. Kim, thank you. Now is the time we get to ask all the hard questions. So as you're thinking of them, I'll start off with one. The data you showed on CAR T therapy looks incredibly promising. And in the setting of really poor outcomes in those disease states where you have distant metastasis, how far are we away from that being first-line therapy in these stage 3, 4 patients?
I think in terms of first-line therapy, we're far off from that because oftentimes when these patients present with advanced disease, they are highly symptomatic, can't really eat, have pain, active bleeding. CAR T-cell therapy, to be able to re-engineer these T-cells takes time. Hopefully we'll be able to speed up that time. I think our lymphoma groups have done an amazing job, kind of the off-the-shelf CAR T-cell therapies. I think right now we're still working on getting it approved in the refractory setting, but we'll continue to optimize it.
Questions from the audience? Yeah.
Thank you for this great talk. Quick question about the treatments where the payload is delivered directly to the cell. What have you seen in terms of the differences in side effects that as opposed to traditional delivery?
Toxicity?
Yeah.
Yeah. It's still chemotherapy. I think when they first came onto the market and in clinical trial development, I think a lot of people mistakenly thought it'd be a little bit less toxic, but we are still dealing with severe myelosuppression in a small proportion of our patients, nausea, vomiting, some infusion reactions too. Interestingly, some of the chemotherapy payloads, we're not seeing as much of, say, like neuropathy side effects as we normally would with more conventional chemotherapy. So I think I've been a little bit more encouraged by some of the other side effects that are associated with conventional chemo. But still toxic, and we really try to identify patients who we think would tolerate it.
Hi, I'm Lakshmi from Infectious Disease. Thank you for the wonderful talk. I had a question about the interesting data you presented about the antibiotics. And so my question was, giving antibiotics after immune checkpoint inhibitors increases? Is that what you found?
Survival, actually. So with immunotherapy regimens alone.
It improves survival or?
No, worsens survival.
Worsens survival. So did you look at how long of antibiotic courses, short courses, what type of antibiotics?
Yeah, good question. Unfortunately, with the Flatiron database, we're unable to get to that level of granularity. We were trying to also pinpoint what type of antibiotic would contribute to poorer outcomes. The sample size overall was on the low side, so it was hard to make any determination there. But one of the questions we also did have before we found out it really couldn't be answered by the Flatiron database was, are these shorter courses like 3-day courses versus like 2 weeks or more? But that certainly is an important point.
Yeah, because these patients present with infectious kind of symptoms sometimes, and the default is to give empiric antibiotics to a lot of people. Should we be avoiding that in that situation is an important question to ask.
Yeah, and it's tough. These patients are already immunocompromised even before they start treatment, I would say. So like I said, I think that infectious disease has just done such a great job really being able to implement stewardship. But even more than that, I think we still need to, really think about what we're doing. As oncologists, we deal with big medicines all the time. And I think we're a little bit lax in doing a little bit more antibiotic stewardship ourselves, especially for outpatient medications.
Thank you.
You've got an ID doc holding the mic, so I'm going to follow up that question. You talked about the microbiome potentially being a risk factor for development of these types of malignancies. Have we looked at antibiotic use in children and adolescents as a predictor of a future malignancy, whether it be related to disturbances of gut microbiome or whatever? Has that been looked at in this?
Yeah, I don't think we have any robust data about childhood antibiotic exposure. Most of the data that we've seen is emerging out of colorectal cancer, obviously. And that seems to make more intuitive sense because, these cancers, the carcinogens kind of sit in the colon far longer than the esophagus. We are planning on our research day to incorporate some investigators on campus. Christy Coons, rheumatology, obviously she does a ton of work in the microbiome in the rheumatology setting. But we also have cores here, and we would like to investigate this further. Interestingly, Sachinwani, we have this, I always forget what it's called, the EsoCheck.
Capsule to sweet.
Yeah, being able to swallow a capsule and retrieve it again and being able to kind of scrape out some of those cells there. And my dream is to be able to do some microbiome analysis there as well, do this serially and see, who becomes at risk for developing cancers. We do have some contacts in the pediatric center. Again, his name is escaping me right now. Glenn Faruda, yeah. So that's something we could always investigate too, just in his pediatric population. So it's hard because overall, this is still a rare disease in this country. So any of these studies would really have to be done in Asia, I think.
Kind of along those lines, a question from the chat is wondering if you think probiotics have a role in the pre-treatment strategy before starting immunotherapy.
Yeah, I think the role of probiotics is very controversial, at least talking to my gastroenterology clinic colleagues. They seem to be a little bit more convinced by like the prebiotic data, being able to feed the gut microbiome versus like taking, pills or probiotic yogurts. I think I'm not sure. I feel like I haven't seen really convincing data that has helped. There was a trial in Asia that I actually reviewed looking at adding probiotics to patients who were receiving immunotherapy. I don't think that study resulted in any positive data in the patients who received the probiotics.
Last question.
Hi, given the rarity of this disease in the US and more prevalence in Asia, I believe there's like population-based screenings too in Japan and Korea where they screen with EGDs at the age of 50 to 40. What's your guidance on screening folks or patients from these countries, like
Yeah.
when they come to America?
Yeah,
and if
definitely.
we should do it earlier?
I think so. I think patients who are first generation who are in the US, they wouldn't normally qualify for screening every 1 to 2 year, but they clearly have the risk factors from their home country. And what we find is that people of East Asian origin, and I obviously know this very well, the longer they're here, the more generations are here, their risk of developing gastric esophageal cancer kind of normalizes to kind of the North American population. But I think it needs to be a discussion with the internist or gastroenterologist about implementing screenings. I don't know about all the payment and reimbursement hurdles that need to happen in that, but I do recommend to family and friends who are recently emigrated from those countries to push their doctors to have this discussion.
Dr. Kim, thank you for a terrific Grand Rounds.
Thank you so much.